Welcome to the next installment of the Many Minds podcast, where we encourage collaborative community care, pooling many minds for better outcomes. My name's Alex Davis, physician assistant. I'm along here with Tyler Murray, nurse practitioner. The purpose of the podcast, the reason we're doing this, is to explore all of the different spaces where advanced practitioners live and work. We want to hear about all the different specialties and maybe talk about a few of the things that we don't always get to talk about. Help us understand what makes your specialty special so that we can come together and essentially make your job easier, and how can we work better together.
And on that note, general disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not meant to be a substitute for medical, professional advice, diagnosis, or treatment. We're just here to talk, have a good time. And with that, we're going to jump into the episode. We are so fortunate to have two wonderful ladies here with us today. London CEO, founder of Aura Migraine Clinic, and then Rachelle, which is her business partner. To get us started, I just want you guys to quickly introduce yourselves, kind of tell us your background, kind of what led you to the specialty that you're in now.
Okay, great. I've been working as a nurse practitioner for about 5 years now, and I started out actually as a chronic migraine patient in childhood, where I used to get like abdominal migraines as a kid, where I'd have just nausea, vomiting, stomach cramps, misdiagnosed like throughout my entire childhood, thinking it was maybe like IBS or something else going on, bouncing around to GI doctors and primary care physicians and doing a bunch of testing, and finally got diagnosed with migraines when I was in my 20s. So went most of my childhood without any treatment for migraines at all. And then went into nursing, and I worked at Utah Valley Hospital with Lindsay Mortensen, who also works here at Summit.
Yeah.
And I used to work with chronic migraines in the hospital, where I would try to push through the shift. I didn't have a lot of treatment at the time. I would get off my shift, go downstairs to the ER, and get an IV, with an IV like migraine cocktail essentially, to like break my migraines. So dealing with them for most of my life without like great treatments, I finally went to a headache specialist in Salt Lake City, Dan Henry, who ended up being my mentor and my supervising physician for the past 4 years. Finally got relief from him, got on a really good regimen where like my migraines were under super good control. And I decided at that point that I needed to like go into this professionally. And so went back to school, got my NP, and that's pretty much where I'm at now.
I love that.
So
Awesome.
Worked with Dr. Henry for the past 4.5 years-ish, somewhere around there. I think he's one of the top headache specialists, honestly, in the U.S. Amazing. He trained me and Rachelle as well. So.
And that's where you two got to know each other?
Yeah,
that's where you
so
two
we
came
both
together?
worked at Foothill Clinic up in Salt Lake. And we just decided that like Utah County doesn't have any headache specialists that we're aware of down here. Mm-hmm. So we saw a huge need for it. And I mean, with how booked we were in Salt Lake, I was booked out like 6 months for people to get in. I was like, we probably should expand. So that's kind of how it all began.
Yeah.
What was the dynamic there with you leaving that practice and kind of doing your own thing? Was that an easy transition?
It was actually one of the harder things I've ever had to do, to be honest. Like, I had a huge client base there that I was leaving behind, right? Yeah. And so I tried to help, like, I gave them almost like 5 months notice to try and bring on another provider and get that provider trained and things like that before I left. And I did have like a non-compete, so I couldn't really talk about where I was going, but I've had patients that have like Googled me or found me, you know, and are following me down here from that clinic too. So yeah, but it was tough. It was hard to leave Dr. Henry. He was pretty awesome to work for. Amazing. He actually has a foundation, a migraine foundation. It's the Danielle Foundation. They offer like free courses for people with migraines. They do like a mindful meditation course. They're all free online. A mindful meditation course, like self-hypnosis, yoga classes for people with migraines. It's pretty cool.
Is there a story behind that? Like,
he used to be just a primary care physician for most of his life. He had a daughter with really severe chronic, like daily migraines. She had migraine with Aura, which it increases your risk for stroke. It's like a 2 to 4-fold increased risk for stroke if you get the Auras, which
I didn't know
are like only a third of migraine patients typically will get an Aura. So she had migraine with Aura, and she ended up having a stroke from hers, and really struggled after that with depression, which is super common with migraines. It's like it's the second leading cause of disability worldwide, just right after back pain. So lots of our patients are on disability for migraines, unfortunately. but dealing with like chronic pain every day, she ended up taking her life. And so at that point, he just did a full switch and became a headache specialist at that point. And that's what he dedicated his life to. So he's like in his 70s now, and like I don't see any. He's not retiring anytime soon.
No sign of
like,
slowing down.
This is like
his passion's still
That's awesome. You like to see that though, when there's some sort of personal connection and it gives a real sense of motivation. You really know that those providers are out there to help people.
Right.
Yeah, absolutely.
Yeah.
I think that is one thing that helps us as providers, that both of us have dealt with migraines in the past. And so just the compassion that comes from being able to understand the pain that they're going through. Yeah. A lot of people are told that, oh, this is just a headache, like you should be able to push through this, or they diminish their symptoms quite a bit, or just don't really understand how debilitating it can be. Them. Exactly, yeah. So as far as my background goes, I am really lucky. I don't have the same level of chronic headaches like London does, and chronic migraines. I did have quite debilitating migraines when I was an adolescent. That's when they started for me, and that's when they start for a lot of people. And then I am really lucky, and as I grew up, they decreased in frequency. So right now I just have episodic migraines, so I don't have to do a whole lot for them, just take some rescue medications if needed. But yeah, as far as my nursing background, I've been a nurse practitioner for about coming up on 4 years. I mostly worked in primary care, so I worked in the same clinic that London does, or that she did as well, at Foothill Family Clinic, which was a great place. I focused, I would say the majority of my practice was primary care, so I got quite a bit of general experience there, but then I trained with Dr. Henry as well, so that I was at a different location, so I could see some of his patients down there if they needed to, or within the urgent care hours that they provided. So I did do quite a bit of migraine care, but it wasn't like a constant every day only seeing migraine patients, more like London. So, but yeah, it's been really fun to just transition into just treating migraine patients, and it's nice to kind of whittle down from primary care, where everything is so general, to having more of a specialty, which has been fun. So,
so now lead us into, Tyler and I know, because we've met, we've actually got to come out and see your space, which is impressive, by the way.
Thank you.
But I think people listening maybe haven't quite keyed in yet. What is it that you guys are doing now? Tell us about your business and what it is that you do currently.
Absolutely.
Right.
Do you want to take it away?
Sure. Yeah. So right now we're focused primarily on just like headache and migraine treatment. We offer a few things that we don't think many of the primary care providers are offering, or neurology clinics, which is we offer acute treatment where patients can try to come in same day for either it's for like if they've been in a migraine that's not breaking for several days, or it's a super severe migraine, they can't break it. They can come in for a nerve block with us. We do trigeminal nerve blocks and occipital nerve blocks. So we essentially will use like lidocaine, bupivacaine. We do about, let's see, how many injections for that? We do supratrochlear, supraorbital, auriculotemporal, greater and lesser occipital blocks on them.
Yeah. Just bilaterally.
Yeah, bilaterally.
Yeah, let me see.
Pull it out.
Sure,
yeah.
Orthopedics, that's probably not going to help.
Yeah, and that's essentially what it does is it shuts down the trigeminal nerve. It kind of resets things. The nerve is numb for essentially like 4 to 6 hours before it turns back on, and the hope is that that's going to break the migraine cycle. And it's not going to restart the migraine once the nerve finally turns back on. Most patients get about up to 2 weeks of relief with it. If they're really chronic with like a daily migraine that's intractable, they usually see like a decrease in their daily migraines if it doesn't completely break it. So it's a really good option. It only takes about 15 minutes to complete it. The other one we do is we do IV therapy. We have lots of different options as far as like a cocktail of things that we give them. But typically, like a basic cocktail would be magnesium, Toradol, Zofran, dexamethasone. We sometimes will do valproic acid. We have the option to do DHE, which is cool because a lot of times, if a headache specialist is admitting to the hospital, they'll do like a DHE infusion that can go over like several days. We can offer that in the clinic, having them just come back, day after day and get the infusion done to break their migraine cycle. So yeah, that's kind of the things that we do that are like outside the norm. And then we also do like migraine treatment plans. We do lots of preventative oral medications. We offer Botox for chronic migraines. And then we also do some of the newer treatments are monoclonal antibodies, they're an anti-CGRP medication. And migraineurs make about like 30 times the amount of CGRP, which is just a neuroinflammatory protein. It's involved with like the chemical transmission of like the pain pathway essentially, and causing all the inflammation that's associated with a migraine. So these medications are just blocking that protein essentially. And so there's like once a month injections that we can prescribe, and there's a daily oral that's newer, that came out in the past year, that we can prescribe for that too. So lots of new things that have come out in the past like 5-6 years that have been really incredible.
But the way you discuss it, it's like the accessibility. People can get in to see you, whereas if I refer somebody to a neurologist for suspected migraine symptoms, that's 6 months out before they see a neurologist.
Exactly.
And then I don't know how much, maybe you can speak to this, how much primary care does. It doesn't sound like they're offering all those things in the primary care setting.
And really the acute treatment, like you alluded to, is ER, emergency services, and they can maybe stabilize for a minute, but not all of these real nuanced treatments that you're talking about. So this is a pretty unique service.
Yeah. So and there's some primary care physicians that stay really up to date, and they oftentimes can get them started on some good like first line therapies. But I found that a lot of them, like once they kind of use the things that are like tried and true to them, they're like, I don't know what else to do, so I'm going to send you to a neurologist, which is completely appropriate.
Absolutely.
But then they're in this tricky situation where they're just waiting to see someone. And so exactly. It's just the accessibility of trying to get into them and or get them in to see somebody as quick as possible to help them with this debilitating disease, essentially. The other thing that I've noticed is really helpful is like for neurologists as well. A lot of times they specialize or they like to tailor their practices to like specific neurological conditions, and so some of them do limit like or prefer not to take a lot of headache patients.
They screen beforehand. We've seen that before. We've had a few that have pushed back, which is fine because it's not their area of focus, and so but it's so good to know that there's another resource out there. So
absolutely.
Super unique. I love to hear that you guys have this, and it's so good. So on that note though, going back a little bit, maybe switching gears back to the business side of things. So when you made the decision to break away, kind of walk us through all of the logistics, all the things that had to happen in that regard. How long did it take you to fully be ready to say, okay, I'm done, I'm going to start my own thing now?
Right. So I started thinking about it probably like a year before I ended up leaving Foothill Clinic. I'm trying to like lock down a space where I could do the clinic. And then once we actually started, it's been kind of like a little bit of a surprise to us how long it takes to actually credential with the insurance companies. And then there's an enrollment process that occurs after that can take up to 3 months. And so we needed essentially about like 8 months of capital to get the clinic going and like get it through this point to where we're actually being paid from insurances.
Was it just the two of you, or do you have other auxiliary staff and like administrative side of things?
That'd be so nice, but it's just us.
No, I'd wonder.
So,
that's a lot. There's so many different elements of owning a business. So how have you kind of navigated that? Is it just kind of when the trial comes or the difficulty arises, you're like, okay, now we got to react and make this change?
I worked with a nurse practitioner. Actually, like when I was doing my NP rotations, I worked with a nurse practitioner that opened his own clinic in Springville. It's the PACE Clinic, Aaron Hartle. I don't know if you guys know him. And so you actually followed him too, right? Was it you? Yeah. And also NeuroFX. I think the PA or NP that works there also was following him too.
That's right.
Anyways, he kind of like helped guide me. So I went and just sat down with him a few times and was like, how did you get your clinic running? What were the steps to do this? He lined us up with like a good, EMR system that does the billing part of it for us mostly. So that's kind of like off of our plate. And then helped us with like kind of starting the credentialing process. But honestly, it's just been trial and error for us doing all of the credentialing ourselves.
For us. And then I quit maybe 6 months before London did. And I also review medical malpractice cases for a law firm. And so I had the opportunity to go full time with them, which was extremely flexible. So I could be getting paid for that while working like 1 day a week on the clinic with the administrative and the, and essentially the credentialing process. So London continued to see patients up at Foothill and kept that going. So we had quite a bit of overlap as far as like getting the clinic ready to go. And then London quit maybe a month, I think, before we opened doors. Because finances makes a difference. You kind of have to keep the income coming.
Where did you, what's the avenue? How did you come up with 8 months of capital to make this happen?
Mostly we just kind of like, it didn't cost anything to be like working on it essentially.
Right.
So as long as we were able to continue like working, then we were okay. It was essentially just that I needed to make sure that I had enough time to work on the credentialing and make sure that that was rolling along. And so I would just do 410s at my other job and then dedicate one day fully to the migraine practice, work on credentialing that day, as well as like any other administrative things.
We also had like one thing that really helped us too. So the place that we're at right now is being shared by my cousin who does Sleep Utah. He makes like medical devices for people with sleep apnea, essentially. And so he offered us like an upfront, like rent-free time where we could come into the clinic to get it going. So just
and
like
that was huge.
And that helped us a ton.
Absolutely. So that was like massive for us because we weren't paying for a location that we couldn't be seeing patients for, 6 months or so.
Right.
So that was honestly like
having
the biggest
resources is huge.
It's huge.
And connections. I think that was, there's been more connections than I thought.
I always fall back on that. And that's a lot of why we do the podcast and this exact thing here is social currency goes a lot farther than actual currency most of the time.
Absolutely.
Getting out and just being vulnerable, getting to know people and developing relationships is, I think, worth far more than anything else.
Yeah.
It can help yourself, but then also in the world where we're treating patients, I now have a great resource and I know you personally and I can get people lined up with good care because we've gotten to know other people. So I always second that.
And so as you guys have grown, I mean, are you adding in other people? Or do you have financial advisors now? Is it to that point yet, or is it still just kind of figuring things out?
Yeah, we're getting close. We have just a secretary medical assistant right now, kind of to the point where we're starting to need like an office manager type to coordinate everything for us. And so we're finally there. We've only been open since like end of June, so just a few months in.
And what's the volume been like?
As far as patients that we see, we're typically seeing around 7 to 9 patients right now per day, which is pretty good. I mean, compared to what we came from, we were seeing about 18 to 22, maybe a little more for Rachelle. She was doing family practice.
Yeah, it depends on the day.
Right. And one of the changes that we did want to make though, so like with this new clinic, we decided for like an initial patient consult, we wanted to spend a full hour with the patients. So that's like a full neuro exam. We talk about like, do we need to get an MRI or not? Do we need to do lab work, like ruling out other things that it could possibly be, right?
Right.
And then coming with like a good treatment plan for them. For the follow-up appointments, we used to do 15-minute appointments at our last clinic, and so we're doing 20 to 30-minute follow-ups now, which has been really nice. Yeah. So we won't be seeing like as many patients in a day, but it'll be better quality of care and less burnout for us too, because that is like one of the hardest parts about the job.
Totally.
Is the burnout and like not having enough time to chart and do all those things.
Yeah.
So
you've got a whole other plate of responsibility. It's not just as the caregiver, but now also administrator and business owner. So you've got a lot of hats. A lot of different hats. A lot of hats. A lot of different hats.
Right.
Walk us through, I guess, kind of the patient experience in your clinic then. So the person that comes to you is referred to you or finds you by any other means. What's their experience like coming into your office? Because you talked about some of the timing of the visits, but how does that go for these patients? Yeah,
so typically they'll call, make an appointment, and then our secretary will schedule them for a new patient appointment, which is 60 minutes. And so during that appointment, we have them come, we have them fill out some intake paperwork just so we have a good like history as far as their migraines go.
Pretty standard,
Yep, exactly. And then during that appointment, we'll talk to them so that during that like hour appointment, we'll obviously like gather information about what their migraines are like, about their history, and then we go into a pretty in-depth treatment plan. So we talk about different things like natural things that they can do, supplements, lifestyle changes. We try to spend a decent amount of time talking about those things so that they're not like in the dark as far as the things that have been proven in like evidence-based lifestyle changes essentially that can help them there. And then we do talk to them about the different medication options out there. So there's typically 3 oral preventive medications that we talk about. A lot of times we kind of explain to them it's really an insurance game. We have to usually try some of the oral preventives first.
What are the mainstays of that? What do you typically start with?
So depends on the patient, and it depends on like some of the other things going on in their life. Amitriptyline is a big one that we use, especially for patients that have a hard time sleeping because it does make them more tired.
And this is like first line?
Yeah, first line would be amitriptyline, which is a TCA antidepressant. And then we use very low doses compared to like depression, if that makes sense. So people...
different indications, different dosage.
Be concerned, right, exactly. So we keep doses pretty low, which is in line with the standard of care for treating migraines. And then Topamax and propranolol. For some patients that have other I don't want to say abnormal migraines, but like vestibular migraines, sometimes we'll use other treatments as well, different blood pressure medications that have been shown to help with those. But,
interesting.
Yeah, and then we typically try to do a decent trial for at least 6 weeks of each of those oral preventive medications. If they fail all of those, then we move to the more advanced therapies, which work really, really well. We have a lot of patients that respond very well to them, but insurance oftentimes requires that they try other preventives first. So that's when we typically move to either Botox or our monoclonal antibodies. And so we just kind of talk to the patient, let them know that those are like the next steps, kind of get an idea of what they would be interested in. And then we basically just kind of lay out this treatment plan, let them know what we're doing, let them know our next steps, and then they have a better idea of kind of what's to come and how long that process can take. So.
How, as a referring provider, what can we do better to facilitate what you guys are doing?
Yeah, I mean, I think it would be great if you're going to refer them to us to at least get them started on a preventative if possible. Mm-hmm. One of the 3 oral preventatives, it just gives us a head start on the whole plan of what we're going to do with them. Mm-hmm. And then a good rescue medication. Yes. So a lot of times we'll get patients and they're like, I'm just using like Excedrin over the counter, like ibuprofen or Tylenol, which are not the best for migraines, especially Excedrin. Excedrin has been proven to be like one that causes a rebound headache the next day. So essentially it's just feeding this cycle of like never ending migraines. So a lot of times we'll see patients like come and they're having like a daily migraine and they're like taking Excedrin like 2 or 3 times a day. And like we have to wean them off of it. So giving them a good rescue pill is one of the first things. And I would say like choose a triptan probably first. Yep. Some of these newer ones, the Gepants, we like quite a bit that work with the CGRP protein, but insurance will not cover them unless they've tried 2 triptans. So sumatriptan, rizatriptan, naratriptan, any of them are fine. Just get them a good rescue pill.
Pretty safe to prescribe as far as across the board contraindications, side effect profile.
Extremely safe to prescribe. The triptans are contraindicated in severe cardiovascular disease like heart attacks, strokes, things like that. We would skip and go straight to a Gepant, but for the most of the population
it's
totally
constriction, so that's
part
makes
of it.
sense.
Has a little constrictive
and then
properties.
Also contraindicated in patients with true hemiplegic migraines.
Yes.
So that does not happen very often. Most people aren't like that, but if they would honestly probably be in the ER if that was happening. It looks like a stroke.
I was going to say,
like a stroke.
Yeah. But anyways, other than that, they're very safe. Most people respond pretty well to them. And then there's other ones we can do later. Yeah. So, one of the 3 preventatives would be either propranolol. We usually do about 20 milligrams twice a day. Mm-hmm. Topamax, we kind of titrate that one up slowly. Yep. It's not a favorite of our patients usually just because of the side effects, but it does work really good for migraines. Like it's one of the ones that kicks in a little quicker for them. I feel like they're getting the quickest relief with it, but also they'll have some side effects. Sometimes brain fog or tingling in their fingertips with that one. Mm-hmm. But we usually start with like 25 milligrams at bedtime and kind of slowly titrate them up to about 50 milligrams twice a day.
Mm-hmm. And the propranolol, are you worried about like lightheadedness, dizziness?
It's such a low dose. Most people don't.
So even in your younger female population, you wouldn't be afraid to prescribe propranolol?
Mm-hmm. No. Unless they're bradycardic. Exactly. I won't even use that one if they're
bradycardic or if they have really low blood pressure on a like normal basis. If they're typically like under 100 for their systolic, then I wouldn't prescribe it. But other than that, they do just fine. And I have a lot of patients that love it because they will take it. It does help with anxiety. That low of a dose helps with anxiety a little bit. So some of them love it for that too, which is nice. So it's kind of nice to pair it with a few things that they're also dealing with to try to help.
I love that you guys brought up just the idea of like, hey, try the patient on something. We run into this same problem with our process of seeing patients. It's like they come in and they've done no conservative treatment, but yet they want, answers and treatment. And unfortunately, we know as medical providers,
it's always a stepwise approach, and you got to start at the first step.
And we definitely want to be as minimally invasive as possible. So maybe it is a simple medication that makes a big difference. So I'll be honest, I'm a little timid. It's like when I prescribe anything outside of what I'm used to prescribing, I get a little bit timid. But it's food for thought because that could help you guys and help the patient ultimately get efficient care, and that's what we're trying to do, right? We're trying to maintain our efficiency to make sure our patients get the right care that they need. So this is a good thought.
The other thing too is even just touching on how, like, I feel like you are good explaining the guidelines. But as far as like chronic versus acute, because the guidelines have changed quite a bit over the years, because they used to say, I think that chronic was like 15 plus migraines per month, and then now it's quite a bit less. Do you want to talk on that?
Yeah, so chronic migraines now is at least 15 headache days, so they don't have to be classified as migraines, essentially. And then 8 severe migraines. So it could be either one. So even if they're having like just a low grade daily headache, which we see quite a bit of, just somebody coming in, I'm like, hey, I just like have this lingering daily headache. It's like a 2 out of a 10. I can still work through it. I'm not like in a dark room or anything. That still will qualify as like chronic migraines. So they can still get Botox and all those things if they need it.
Yeah.
So
how about, what are the patients that are maybe, I don't want to say inappropriate, but what are the ones that you don't feel like you're the best suited to be treating that maybe have come into your clinic that maybe we should be looking elsewhere, or other issues? Or what are the things that you feel like are maybe not the best patient to send over to you?
We treat most of the weird ones, like all of the atypical migraines.
They want to see everything.
They want them all. Okay.
So, I mean, obviously, we send a lot of our patients to you guys. If they're like an intracranial hypertension patient, idiopathic intracranial hypertension, and they have like a Chiari malformation or something like
Structural issues, yeah,
we'll send them to you guys. So we can still treat them for their migraines, but obviously you guys are going to be doing some things as well with them. So those ones we would refer out. I'm trying to think of ones that we would not treat.
My biggest thing is if I'm concerned about something acute, like a stroke or something else going on, then we obviously send to the ER. So if there's red flags or something's like a brand new headache that's never happened before and they're having a lot of neurological symptoms, don't send them to us, send them to the ER. You know, like as far as like acute care goes.
That's good to know, though.
But but other than that, we do see pretty much everything across the scope of headaches.
Are you typically reviewing imaging with
we do.
each of your patients?
We review their old images, and then if we feel like it's appropriate, like if they're having any, like we call them red flag symptoms, right? But it's like thunderclap headache, first headache, worst one they've ever had. Later onset migraines for like older adults, we always do an MRI. We look for like giant cell arteritis with those patients sometimes if they're over the age of 50. And then we do like lab workup on them. But yeah, red flag symptoms like numbness, weakness in the arms, right? Stroke-like symptoms, all of those are going straight to the ER.
Yeah.
So
double vision. We were just talking about that the other day. We don't have the ability to like review the images themselves. We typically just review like the radiology report.
Just the report.
So we don't have the ability to like view it on our computer system right now. But anyways, typically a lot of people have actually already had some of a workup, so it's actually really nice when they come in. They're like, oh yeah, I just I already had an MRI of my brain and that was like last month and it was normal. Anyways, so it is kind of nice when that happens, but we're happy to help. Yeah,
that's awesome.
Backing up just a little bit, so just maybe for the listeners, not so much myself, really for myself, but
pretend Tyler is 5 years old.
Exactly.
Okay,
so
perfect.
When you're diagnosing, so when patients come in and like, oh, I have a history of headaches, I've always wondered, when does it transition to migraine versus headache? How do you make that distinction?
Especially we're understanding, knowing that aura is not always a prominent feature.
Exactly.
Yes.
So what classifies says this is migraine?
So headaches, we kind of describe this to our patients as like headaches is just head pain. A migraine is like a full body experience usually. So it comes in 3 phases. There's like the prodrome, which can start like 24, even 48 hours before the actual head pain starts. Patients will start getting symptoms. It can be like irritability. Some people will yawn. People get like sensitive to lights then. Everyone's is a little bit different, but you can tell that like something is building, right? They can usually feel that. And then the migraine itself is obviously the worst part of it, with the head pain, the nausea, the vomiting. So we usually have like, it's affecting your GI tract. We get some gastroparesis. There's like a shutdown that happens when the migraine occurs. So a lot of people have nausea. And then the postdrome is like, we call that the hangover day, where you don't really have a migraine, but like just feeling like you got run over by a truck, essentially. Brain fog, not thinking clearly, just not feeling super great. But so from a headache to a migraine, we say that migraines are head pain plus one other neurological symptom. It can be light sensitivity, sound sensitivity, smell, or nausea or vomiting, essentially. So it's a headache plus one of those. And that classifies it as a migraine. They don't have to be unilateral, although most people's are, but we do see migraine patients that have it on both sides. So it doesn't have to be a unilateral. They don't have to have an aura. only a third of migraine patients have auras. So we just essentially say like, hey, do the lights bother you when you're getting these headaches? Oh yeah, I'm like, I can't look at my computer screen, or I have to shut the blinds in my room or whatever. That's a migraine.
Gotcha.
So it's more subjective symptoms.
Right.
That prodrome sounds like every night at my kid's bedtime. I'm irritable and fatigued. The noise is bugging me.
So
Yes, totally.
I can relate to that about every night of the week.
Yeah.
For sure.
How about the acute patient? What does that look like if we see somebody that is just miserable and they're struggling and all of those symptoms that you're discussing, and we call up and say, hey, is this somebody you could see today? And if they're able to come into your office, how does that visit go? Because I feel like they probably are not going to be super receptive of, let's try 6 weeks of amitriptyline.
No.
Yes.
Right? So that's got to be a different scenario.
Right.
Absolutely. Do you want me to talk about it?
Yeah, go ahead.
So if it's an acute migraine and it's actively going on, they're like, I am miserable. Most of the time you can tell, although some people cope super well, but a lot of times people are like covering their eyes, or they have sunglasses on, or they're like, I'm so sorry, but I can't fill out this paperwork because it's too much, Too much stimuli. Yeah, exactly. Then we'll get them in, and typically we'll do either an IV or a nerve block on them. So if it's a new patient, we obviously would do like a full neuro exam, make sure there's nothing else going on. And oftentimes if it's a new patient, then sometimes after their treatment, if they're feeling a little bit better, then we can talk to them about some of like their treatment plan or get them scheduled for something like that. But so if we do the IV, like we talked about, they'd be there for about an hour as we give them the IV, as well as medications that can help break the migraine. And then if they opt for a nerve block, then we would just proceed with that. That takes a little bit less time, so it kind of depends on what the patient's schedule is and how long the migraine's been going on, what they feel the most comfortable with.
Yeah, that's an awesome
Does that answer
resource.
your question?
It does, absolutely. Okay. Yeah, that is an awesome resource.
We're happy to see them, and then we'd want to get them scheduled just to make sure that they have a good treatment plan moving forward with it.
Of course.
Is that type of treatment covered under insurance? Like if you're to do an acute therapy for somebody in that situation?
Yeah.
Yep, it is.
That's good.
Nerve blocks are the ones that are kind of weird. So we kind of have a sheet for ourselves that there's some insurances that will pay for some of the nerve blocks and not other ones. And so typically we just keep track of that. We bill for the ones they cover and we don't worry about the ones they don't, type of thing. And then we have, and then if they have any issues, then they can always let us know and we can kind of work with them on that.
That's good.
The nice thing with like acute treatment too is that the patients don't have to have a driver. So like for a nerve block, we typically keep them there for 5 minutes and they're safe to just go back to work if they need to afterwards. Their headache is usually gone by that point.
And it's like almost immediate relief.
Right.
It's great.
And then with the IVs, if they want to have like a more extensive treatment that's a little bit more effective, they can have a driver come with them, and it would be more of a 2-hour treatment where they get a couple different additional medications that make them a little bit tired. But if they don't have a driver, that's fine too. They can still do like the main IV cocktail and it works really great. So
That's
very
awesome
cool.
resource. Maybe just a little bit along, we're jumping back and forth, I know, but the billing side of things. So the finances, I know that owning a business, I watched Summit grow. I know there's a lot of overhead expenses, but I want you to just talk a little bit about your projection of how much you think how well you think you could do in this specialty with your own practice, maybe comparing it to what people would think is a standard pay scale for an advanced practitioner.
Right.
Yeah, because I think you guys probably have good experience there, having worked as nurses, worked in family medicine, being employed with a clinic, and now this other avenue. Kind of how do the finances all compare?
Yeah. Right. It's kind of hard to say at this point.
I know. We were like, ask us in 5 years.
I know.
We'll probably have a completely different answer.
Are we talking about today, or are you looking at tomorrow maybe?
I know. Today, no one would do what we're doing. But but no.
So where we came from, like Foothill Clinic, I was working part-time up there, and I felt like in the headache specialty, like I was doing pretty good. I'd say like I was, close to like a full-time employee salary at that point, working just like a couple days a week. So that was really good. At this point in time, we're hoping that we can have like a good work-life balance where we can work, both of us can work part-time there, and hopefully make a full-time NP salary at that point, is what kind of we're projecting.
That's our projection,
Yeah.
About like working about 2 days a week in clinic, like seeing patients, and then receiving about a full-time salary.
More or less than 150,000.
About.
I would probably say like I would expect less in the beginning, but I think it could probably reach there
With 2 days of work.
Yeah. Which would be great. I mean, we'll let you know.
Yeah.
But
okay.
We'll keep you guys posted.
We'll do a part 2.
We're not there yet.
Part two.
Right now.
Yeah.
we're not making like anything right now, but we
we're staying
also
afloat.
we're doing fine. We're
paying all of our employees. We're getting all the supplies there.
The clinic
it's an
is
early sacrifice.
like the priority to
I think
than our own salaries. So
probably
long-term payout.
Probably underappreciated. I'm sure that people have not done it themselves, may not know.
Right.
Yeah.
All that goes into that.
It's quite the process.
Yeah.
So
But the demand has got to be there. I am sure that you're going to have the doors open all day, every day, and people coming in. Yeah. What a valuable
We just sent a
resource.
referral today.
Yeah.
We ran into somebody at lunch.
Thank
We're
you.
excited.
Said, my headache is killing me.
Yeah.
I said, you should listen in a couple weeks.
Yes.
Or go see
we're
him
happy
tomorrow.
to see him. Yeah, absolutely.
So a couple common trends or topics that we like to discuss. A lot of them is what's trendy in your space. And I feel like, honestly, your entire space is trendy. That's what we talked about, is all the new innovative things you're doing.
Right.
So I think we're covered there. But the last thing we like to talk about is just story time.
Perfect.
We love to hear fun, interesting, motivational patient stories, because everybody's had their experiences. How about you two, Rachelle and London?
Do you want me to talk about like a funny one or like a serious?
I always say this. I love funny.
Funny. Okay,
I love funny.
So I have had this patient for a few years that has really chronic migraines, comes in for nerve blocks like all the time. And a lot of his pain is like trigeminal, like into the sinuses. And so he comes in and he was like, hey, I was doing some research and I think I'm having a sinus infection. And I think if we can increase the blood flow to the sinuses, then I should be able to get resolution of these much better. And so can you prescribe me Viagra?
Is that off label?
Right.
Let me do a quick
And I was
Google
like,
search
well,
here.
I've never heard of it being prescribed for that. And it's going to make your chronic migraines like way worse. You're going to get a migraine for sure if I give this to you.
Yeah.
He came in like 2 separate times and asked me for Viagra again for the same reason. He's been very persistent. And I still haven't prescribed it to him, but just like some funny things like that.
That's awesome.
I have had like a few, like a lot of my patients are really depressed, like coming in with like suicidal ideations and stuff like that. Just sick of having a daily migraine. One of my patients would come in like every single week and get an IV and cry to me about like her family was going on a cruise and she couldn't go because she doesn't want to be like the Debbie Downer, you know, like she doesn't want to go and be like, hey, I'm in pain, I can't go to the beach, or I can't do this. And so like over time, we finally got her on a really good regimen of like medications. I think we ended up doing Botox and a monoclonal antibody for her, plus some of the oral preventatives. She was on like a cocktail of just different things, trying to hit it from every angle. She is like night and day better, just able to like go on vacations finally. One of the things that she really wanted to do was to go back to church, because she hadn't been able to go to church for years because of like the lights in the church and like the sounds and everything. So she was able to go back to church, like totally turned her life around. So these are the ones that like keep me going. I'm like, okay, I'm making a difference in people's lives. No longer depressed. And I think it's nice because I also can relate to that as well with like how bad my migraines have been. I try to say like, hey, I was the same as you. I was having like 25 migraines a month. I'm down to like 4. You know, you can get your life back. So those are the ones that I like to hear. But
Absolutely.
Do you have anyone you want to talk about?
I really don't have a lot of like funny migraine patients.
Right.
But
there's nothing funny about a migraine.
Not a lot of
but like my favorite ones are the ones where it's fun to treat migraines for me and headaches in general, just because there are options, and people a lot of times feel like they have no options, where they're like, well, you know, I saw someone, they gave me this one medicine but it didn't work, and then like either they stopped, you know, they didn't like follow up with their provider, or they didn't think there was anything else out there. And so it's fun to be able to like see the change in their life when they have that improved quality of life. That's been really fun. Right. I think it is funny too, like we are really used to seeing patients with chronic migraines that don't respond to some of the first line therapies, and so it's kind of funny when we have someone that we're like, they come back and they've been on their propranolol for like a month and they're like, they're gone, and we're like, it does work for some people. It works, So it's kind of fun when that happens too, where we're like, I love that for you, you know.
Right.
But anyways, that's fun too, because sometimes they'll need a lot more, but we just get used to those really complicated patients. So
that's great. We appreciate you sharing. That's been a lot of fun. We should probably wrap this up. Tyler, what do you think? What'd you learn today?
I know you were going to ask me that. I've got a lot of things going through my mind right now. No, honestly, I feel like I'm super impressed, first and foremost. Like for you ladies to do this is like such a need for the community, first and foremost. And I think it's a a specialty that I would need a lot of training to do, but I'd love to get more involved in any way I could.
I'll have to dust off those anatomy and physiology books, maybe.
I'm telling you. But I love the drive. I love the passion. And I can tell like the listeners, like if you want to be treated by somebody who knows the condition, you guys sound like the best place to be and the most accessible. And I really am grateful for your time here today and teaching us. I'm going to have to go back and listen to it a few times to get all the medications down right. But thank you so much for sharing what you guys do, and really appreciate you coming on the show today.
Yeah, thank you.
And if somebody had follow-up questions or wanted to get in touch with you or find your clinic, where would people be able to communicate with you?
Right. They can find us on our website at auramigraineclinic.com. It's AURA Migraine Clinic. And then our Instagram handle is at Aura Migraine Clinic. Mm-hmm. So you can find us there. Yeah. We treat all kinds of different, like really atypical migraines, cluster headaches. Mm-hmm. There's like one called SUNCT, paroxysmal hemicranium continuum, and all the really complicated ones. So if you have a complicated migraine, come and see us.
Or if it's uncomplicated, we love you too.
Right. So waiting to get into
no bias. No bias.
Right.
No bias.
You can't get into a neurologist. Come and see us.
Love it.
Happy
Perfect.
Yeah,
well,
thanks for having us.
Yeah, for sure. With our office, we are Summit Brain, Spine, and Orthopedics. You can find us on Instagram at Summit Brain, Spine, and Orthopedics. Our YouTube channel is Summit Medical Institute. And my favorite is we like to communicate with people in person. Come see us in person Tuesday mornings at our interdisciplinary case study rounds discussions, 7 a.m. Tuesdays at the Mount Point Hospital in Lehigh. Special shout out to our production team who make this all happen for us. We appreciate everything that they're doing. And we'd always love to hear from people that are listening to the show. Give us a comment. What have you enjoyed? What are you looking forward to? Who do you want to hear from? I think we've got some excellent ones coming up in the next couple weeks. So stay tuned.
Some excellent ones.
This has been fantastic, but stay tuned. We look forward to the rest of this. So this has been another rendition of the Many Minds podcast. Many Minds for better outcomes, encouraging community collaborative care. We appreciate you. We'll see you next time.
Until next time.
You're all you